Hi, everybody. Hope you're doing well today. Welcome to the fourth of our series of online discussions for the Mental Health Technology Transfer Center of New England. I am very excited to be connecting with all of you today. So just so you know, this is the fourth of our series of online discussions, really focused around implementing real-world evidence-based services for early psychosis and clinical high risk for psychosis. Today's discussion is about evaluating outcomes that are important for speaking to insurance companies or payers. I'd like you all to take a moment to introduce yourselves by typing into the chat box. Let us know where you're tuning in from. It's always really nice to find out where folks are coming from and where the priorities and what people are thinking about when they're coming on to this call. My name is Michelle Friedman-Yakubian, and I am calling in from Cambridge, Massachusetts. And the goal of this series is to bring together leaders, clinicians, administrators, and other stakeholders that are interested in working together to increase the feasibility and scalability of specialized early psychosis and clinical high risk for psychosis treatment. We have a great group of guest speakers in the series that have been sharing their experience with finding ways to make it feasible to provide high quality prevention services for youth and families affected by early psychosis or signs of clinical high risk. The format of each discussion in the series includes a 30-minute presentation by an invited expert, followed by 30 minutes of questions and discussion by participants. We really hope that you'll choose to keep your cameras on today and actively participate in the discussion. I think everybody gets a lot out of it when folks are actively engaged and taking part. And it's our hope that some of you will use these discussions as a chance to network and to develop some working groups to try out strategies that we discuss in order to advance some of the initiatives by making quality coordinated specialty care programs accessible for youth and families that can benefit from it. So now my colleague Rachel is going to share with you some housekeeping information to help you get the most out of participating in the discussion today.
Hi, can we go to the next slide, please? Hi, everyone. This is Rachel. I'm the project coordinator for our Early Psychosis Learning Collaborative. I just wanted to review a few housekeeping items with you all before we begin. So participant microphones have been muted at entry, and you'll be able to mute them during the discussion portion. During the presentation, if you have any technical difficulties or questions about the topic, please use the chat or the raise hand feature during the discussion to have your microphone unmuted. This discussion is being recorded and will be available for viewing at a later time on the METC website. And to reach us after the webinar, England at ttcnetwork.org. And the next slide, please. So our MHTTC's mission is to use evidence-based means to disseminate evidence-based practices across New England. Our area of focus is geared towards recovery through recovery-oriented practices and support services within the context of recovery-oriented systems of care. Next slide, please. To ensure the responsiveness of our work, we will actively develop and maintain a network composed of different stakeholders from each of the 6 states to guide our activities. And next slide, please. And to learn more about us, you can visit our website as well. And with that, it's my pleasure to hand it back over to Dr. Michelle Friedman-Yakubian for introductions.
Hi again, thank you, Rachel. And again, just want to encourage people to turn on their microphones and their cameras. I'm looking at the list of folks participating today. Some are old friends and colleagues and folks that I know have a lot of good things to share and say in this discussion. So we have a really terrific presenter today who is going to be leading this discussion on assessing outcomes that speak to payers. This is a really nice follow-up to our discussion last week with Melissa Rowan that talked about efforts to negotiate a bundled rate with insurance companies for coordinated specialty care. And so it's my pleasure to introduce Ian Lang, who is the Chief Executive Officer of the Brookline Center for Community Mental Health. This actually is the parent organization for the Cedar Clinic that I am the clinical director of, and one that I've mentioned a bunch of times on this series. And so Mr. Lang has been the Chief Executive Officer since 2017, where he led the center's efforts to expand access to critically needed mental health services for Brookline and Greater Boston residents. Prior to coming to the Brookline Center, Ian served as the Executive Director of Continuum Behavioral Health, a behavioral health provider launched in late 2013 with the goal of creating a comprehensive system of behavioral health care for Rhode Island's commercially insured population. Previously, Ian served as the Chief of Staff at Health Source Rhode Island, which is Rhode Island's health benefits exchange, Vice President for Advancement and External Relations at the Providence Center, and as Chief of Staff at Massachusetts Department of Public Health, where he was instrumental in leading a redesign of the state's substance use treatment delivery system. Ian has a bachelor's degree in religious studies from Trinity College, holds a Master of Business Administration from the University of Rhode Island, and he resides in Natick, Massachusetts with his family. So it's a pleasure to introduce Ian Lang, and Ian and I work closely together, and we've been really, he's been sharing his perspective and how we think about expanding accesses to services of the Cedar Clinic and payment models. And so really delighted to introduce him to all of you and to start off this discussion. Thanks, Ian.
Thanks so much, Michelle. I really appreciate it. And I certainly appreciate the opportunity to speak with all of you today about this topic. You know, I think over the last 20 years, I've spent my career in both, as Michelle just mentioned, in both the sort of community mental health side as well as the payer side and the government side. And so I think I've come to understand the system from a lot of different perspectives, the perspectives of both sort of the service provider as well as the payer for these services. And so what I've found is that there's often this disconnect between the two sides. And I know all of you out there who've worked, dedicated your lives and dedicated time and attention and effort to designing these great programs that are there to serve the most, the most fragile members of society. That's what you're focused on. That's what you're doing each and every day. And and if your experience is anything like my own experience, you sit down and you think about the clinical flow and the intake of how you're going to get patients in and what type of providers you need to provide these critically needed services, and what are the outcomes you're going to be looking at so that you can show that this service will make a difference in the lives of the people you serve. And so you spend all of this time, and then you say you have this program, you've designed it, you're ready to go, and you bring it and you figure out how are we going to pay for it, and then you go to the insurance company and pretty quickly you realize that you're just hitting your head against the wall. You walk in and you talk about the great work you're going to do and the great outcomes you're going to get, and they don't understand, or the perception is they only want to deny care. They want to prevent the people that need these critically needed services from getting that. They are risk averse. They'll say, well, can you prove that this new completely untested model that you've got all your outcomes set up and you've got everything there, can you prove it works? Can you show us it's going to save money? Can you all of these things that you really just aren't ready to do? And I think there's this perception that all the insurance companies are there to do is to say no. They never say yes. All they do is say no, whether it's no to care for the individual client or no to the program that you're trying to push forward or develop. And I think a lot of this happens because when we go into the insurance company, when as providers we move forward and try to take these new and innovative programs forward and try to figure out better ways to provide care for the clients who so desperately need it, we forget oftentimes who the customer is. we are so focused every day and so driven every day to make sure that we're providing really high quality, great care for the people that come in front of us and the people who so desperately need it. And so when we walk into the insurance company, we automatically assume that they both value, that they have the same set of values, that they have the same focus on the people that we're serving, and the same thing that motivates us motivates them. So instead of looking at them and saying, what is it that you are looking for? What is it that you want as the payer for these services? We tell them what we want as the provider for these services. And I'm not saying this in the context of a value judgment. One of the things that was really helpful for me in my own career was when I worked with the health exchange, starting the health exchange in Rhode Island. One of the things is I got a much better understanding of why insurance companies make some of the decisions they make. And while they can be incredibly frustrating from a payer perspective, from a provider perspective, there's a rationale behind it. And so we all have a different sort of series of factors that we have to recognize when we're making decisions, when we're using resources. And so I think it's really critical that as you move forward and as you start to engage with insurance companies, or who are going to have to become a funder for a lot of these services if they're going to exist long term, you're doing it by thinking through sort of what are they looking for, and how do we design systems and design outcomes that are going to speak to them. So that's sort of what I wanted to spend some time talking about throughout this presentation. So the next part, so the question I've always wondered or sort of talked about with different people is, why do insurance companies pay for gym memberships, right? So I want you guys to think about this, and then I would love it if you would just send me your thoughts throughout the meeting, throughout this discussion via the chat function, and just tell me what you think the answer is. Why do insurance companies pay for gym memberships for their members? And then we'll talk about this a little bit at the end, because I think it's useful to understand it in the larger context of what drives an insurance company. So what does matter to insurance companies? And obviously this is a generalization. There are good insurance companies, there are bad insurance companies, there are those that will do everything they can to try to create opportunity for their members, and there are those that really are very much driven by the bottom line. But in general, here's a couple of things that I think are important to remember as you sort of move forward. First, when an insurance company is looking at cost, it's looking at the total cost of care for all the members under its umbrella. So, and the reason for that is that the total cost is going to ultimately drive the premium increase. And that's true whether the payer is a state like a Medicaid or a Medicare, state or federal, or whether that is a traditional sort of private insurance company. Basically, the general business model of an insurance company, as we all know, is they take all the premiums that are paid, they look at the risk of the population, and then they're trying to balance what is the premium cost, or their tax dollars or whatever, the money that's coming in. They're trying to build up a healthy enough reserve so that they can then pay the claims for people who need those services. So in their mind, when you're coming towards an insurance company to say, here's this great new program, this is something that you should offer to your members, they're immediately thinking about, okay, how many people are going to need it? How much is it going to cost? How much is it going to increase my overall cost? And how am I ultimately going to pass those costs on to the people who who decide to buy my insurance? And then, so I think that then leads us to the second point, which is who purchases health insurance. So this is some data from the U.S. government. It's a couple years old. I should have cited it, and I apologize for not citing it. But it was, I think it's about 2017. So 56% of people are insured through their employer. A little under 20% are Medicaid. About 17% are Medicare. Only 16% of people are direct purchasers of insurance, and that number has actually increased in the recent past because of things like the health benefits exchanges across the country. And about 5% are military. The major thing to take away from this is that for the vast majority of people, so about 84%, other than those people who are directly purchasing their own insurance, the decision of whether someone stays with a particular insurance plan is not the members', it's their employer, it's the government, it's someone else. And so when you think about this in terms of the insurance company, the person who's deciding whether to send their book of business to a Blue Cross or a United or a a Beacon or a Medicaid plan or whatever the insurance, the predominant insurance company in your area is not the person who you're providing service to. It's the person who's paying for that service. So it's their employer or it's the government. And so when insurance companies are looking and thinking about who their client is, they're not necessarily thinking about their individual member, though clearly member satisfaction and everything is important. But I think that they're also thinking about who's ultimately going to pay for that service, or decide to enroll in that particular insurance company. It also means that there is a tremendous amount of churn of people in terms of people who are using insurance. So because I don't know what the latest statistics are in terms of job changes, but certainly most people change jobs numerous times. Most companies are re-looking at their insurance plan every year. I know as the CEO of the Brookline Center, we just finished our whole conversation with our insurance. We had to re-up our plan, and so our insurance agent came in and talked about all the different plans that were out there, and we had to balance the cost of each individual one and whether the benefits they offered. So the challenge then is that most times, or many times, the person that an insurance company is paying for, the insurance company is working with, is not necessarily a long-term member of that insurance company. This was some data that I found out of Michigan, and I don't have any reason to believe that it's not relatively representative of the rest of the country. But as you can see, huge percentages of people are changing their plan every year. So that means they might be starting as a Blue Cross member or a United member in year one of a plan. But over the course of the next few years, they could be on 2 or 3 or 4 different health insurance plans, which means that if you're designing outcomes measures that are long-term, that are going to take 5 or 6 or 7 years to realize, the chances of that person still being on the plan that they started on are pretty slim. So the amount of churn, and not only is it slim because they may move on, they may change their jobs. It's also slim because the government may decide to purchase insurance through a different provider, or their employer may decide to purchase insurance through a different provider. So there's just a lot of churn. And so that's something to remember as well, that the outcomes that you're thinking about have to be both short-term and long-term. And we'll talk a little bit about that towards the end of the conversation. The last thing to remember is that NCQA matters. So NCQA is the national they're the gold standard for insurance payers. And so when you're thinking about the outcomes that you're driving, you should always be thinking about what does it mean to the insurance company. So this is of things like access and availability of care, utilization, et cetera. Specifically to behavioral health, here are what NCQA has considered the quality metrics for behavioral health. And what you'll see is that there are things like adherence to medications, follow-up after emergency room visit, follow-up after hospitalization. All of these things are things that matter to an insurance company. So as you're thinking about your own programs, making sure that oftentimes, I know in conversations with Cedar and Michelle and her team, one of the things that we're most proud of is that there are often, we've really been able to prevent a lot of hospitalizations, right? So we know from the patients we're seeing that a lot of them don't ultimately end up in the hospital. But the key is to make sure we're capturing that, because that's something that's super important to the insurance company. So that's just, those are specific behavioral health quality metrics, but I would urge you, as you're thinking about approaching an insurance payer or talking about this, making sure that you've sort of built this in to your own quality metrics, your own outcomes, because it's something that will absolutely have an impact in terms of how the insurance company approaches or receives the proposal that you're making. Behavioral health also has a unique struggle. So the insurance system has not had to deal with behavioral health for as much in the past. So we are, what I like to say is in many ways, we are 25 years behind the rest of medicine. Not through any fault of our own, but because for so long we were treated as a secondary provider. We weren't really seen as a medical provider by the insurance industry. That's changing. And I think the insurance industry is definitely sees us as a critical component of the larger medical industry, but at the same time, as we've made that transition, they want certain things that we just haven't done yet. So I think first and foremost, they don't understand behavioral health as a chronic condition oftentimes, which means that they're looking for outcomes that are a lot shorter term than they really should be. And so that's a challenge. I think oftentimes the treatment system as it currently exists very separately from insurance. One of the real differences between mental health and physical health care is that a large number of providers of mental health services don't take insurance. And this does a couple of things. First and foremost, it actually decreases the true cost of behavioral health to the insurance provider. So in some ways, it's in their mind, in some ways, it's kind of a win-win, right? So if much of the treatment system is outside of they're not paying for it because people, close to 50% of psychiatrists don't even accept insurance at all across the country. And the majority of private practices don't accept Medicaid, at least as far as I don't have any, that's not a statistic, that's just my own sort of analysis of talking to people. That means that, this huge group of needs is actually being funded outside of the insurance system. The other thing that becomes a real challenge is the lack of outcome studies. Now, this is not the fault of any of us. There have been millions and millions of dollars and probably billions of dollars spent on looking at the outcome of a particular cancer treatment, looking at the outcome of a particular diabetes treatment, name your chronic condition or name your high cost condition. There haven't been that same amount of dollars geared towards long-term outcome studies on the behavioral health side. So that therefore we don't have that information, which then therefore creates challenges for us as we were trying to talk to insurance companies who are now saying we need that information. If we're going to fund your particular approach, we need to see what the long-term outcomes are, and we just literally don't have them because we've never had that funded to the scale that other sort of high-cost medical conditions have been funded. I think we continue to be seen as a cost add, not necessarily a cost saver, though I think that is changing. I think that there has become more and more of an understanding of the ability of behavioral health to save money, because I think as we all probably understand and know, many medical costs are driven by behavioral health, whether it's anxiety or depression or other mental health conditions. These are driving the utilization of the healthcare system, and so I think people are starting to see that. But that hasn't really fully baked into the system yet. And then the last thing, and this is a challenge for us that I think we as a field need to start to try to figure out, is that we have historically been very resistant to looking at outcome measures, standardizing treatment, standardizing at least enough of treatment so that we can say, yes, this approach works and I can show you how it's going to work over time. What my experience has been on the behavioral health side is that most people will say things like, oh, well, everyone is different. We can't possibly standardize. And that doesn't mean that we shouldn't be standardizing the individual care that someone gets, that we shouldn't be looking at their condition and trying to serve their specific needs. But it does mean that we have to be able to say to an insurance company, look, if you have 100 people who get this intervention, here is the likely outcome for this versus 100 people who don't. We cannot, if we're going to move this into the insurance world, we have to do a better job of making that argument. So a couple of things that I think that we need to think about as we do this, and as you think about approaching insurance companies and talking about the programs, talking about the programs that you've designed. First and foremost, I think you need to make sure you incorporate outcomes across a number of areas. Oftentimes what my experience has been is that most of these type of programs focus first and foremost on the on the clinical outcomes, and those are absolutely important. But we don't also think about the other outcomes. So as you think about this, make sure that you're designing outcomes around the clinical, patient experience. One thing that a lot of insurance companies are held accountable to is sort of how easy is it for someone to get in for services? Are they satisfied with the services they get? That sort of that patient experience, both from your own perspective, but also sort of from the insurance company's perspective. Clearly, medication compliance is something that has to be taken into account as you're building these outcomes, because if it's not, then that's not going to speak to the insurance companies. The NCQA standards are super clear that is an important outcome that insurance companies are going to be held accountable to. So your programs are going to need to make sure that they're building those in. And then clearly the main argument, or one of the major arguments that behavioral health is increasingly trying to make, is that we can have an overall impact on the total cost of care for an individual. Because we can help them manage their behavioral health conditions, we can actually reduce the overall cost of care. So we can, while we might spend more on additional behavioral health treatments, what we'll see is a reduction in treatments in other places, or in costs in other places. And so I think you've got to be looking at figuring out at least ways to set that conversation up with insurance companies about how you're going to be able to drive down the cost overall of care for people. And then, as I said earlier, it's critically important that you both look at short and long-term outcomes, because of those things like member churns, you need to make sure that people have the the return on investment is fast enough so that an insurance company feels like it can make that type of investment. So I want to talk a little bit about a specific program that I ran that I think sort of helps make some of these points. There's a program called Health Path. It was in Rhode Island. I ran it from inception until I left to come up to the Brookline Center. It was actually a partnership between my company, Continuum, at the time, and the Blue Cross and Blue Shield of Rhode Island. It was as far as we were able to determine, it was the nation's first health home program for commercially insured and Medicare adults. So it was a program that really took the assertive community treatment model, which some of you may be familiar with, but that's really a treatment team approach. You've got providers, we had prescribers, and we had clinicians, and we had case managers, and we had peer specialists and nursing, all sort of working together to provide care to clients. We received a bundled monthly payment that covered all services. So this was we received an amount of money that was basically, as many services as we provided. We had a minimum amount of services that we had to provide in order to qualify for the payment. And then after that, it was all based on sort of an average across the month. And then we had, the program was expected, so basically enrollment in this Health Path program, the idea was that we would work with people really intensively for 9 to 12 months, and then that they would be able, in most cases, to transition back to sort of a traditional outpatient level of care. And we saw people from a wide variety of diagnoses, personality disorders, mood disorder, bipolar, substance use, and psychotic disorder. Also, about 50% of the population that we served there had a co-occurring substance use disorder. And that is another thing that the systems have to be really careful about, making sure that you don't divide that, because so often there are co-occurring disorders in the populations we serve. And that's something that we have to be very cognizant of. That population specifically, just one thing, just to give you sort of an insurance speak. Basically, what Blue Cross did is looked at them, and they run a bunch of different tests on their population. And so what they basically found was that the insurance risk scores of these patients, and this is I couldn't even begin to tell you how they get at this, but it's a formula that they use. And so what they basically found was that this population was about 18 times riskier than the average population that they served. And so really, in many ways, riskier means more costly. And so these were people with medical spends approaching $100,000 a year. and had often had, I think there was at least a couple of, they'd had to have had an inpatient admission for a mental health condition within the last 6 months, but often they'd had multiple inpatient admissions. So we did this with Blue Cross. We had a partnership with them. And so this was a great opportunity to build from the ground up a model that could work both for the provider perspective and for the payer perspective. And so this is what we basically created. And so we worked together to create these outcomes. And I recognize that oftentimes people aren't going to have the opportunity to work hand in glove with an insurance provider to design outcomes. But this is, this is what we did when we were both at the table. And so what you see is a real outcomes over a wide area, wide variety of stuff. So we talked about sort of pilot participation and program retention, where people who coming into the program, were they staying in the program? Were there barriers to entry to the program? Because one of the things they were very interested in and very concerned about was if people who needed this services not able to access it. We used a tool called the DLA, Daily Living Assessment, which is a tool that basically looks at people's functioning across a number of different factors in terms of their lives. So that's what we had used. It was an outcome tool. It had been, certified as an outcome measure. So that's what we used as our clinical baseline. We also tracked days in community, because what we were doing was trying to prove that our program was getting people out of the hospital, which is both a cost issue and a quality of life issue for people. And so that was important both from the insurance company's perspective, but also our perspective. We are providing care to really sick, we were providing care to really sick individuals. And we wanted to make sure that their quality of life was good. And then we obviously looked at readmission rate. So I won't go through each of them, but that was sort of our customer care and experience. And then we looked at sort of the administrative and operational. That was really more for how the partnership between us and the insurance company was working. But we also looked at the market impact. So were people accepting it? Was there positive brand recognition? Because our belief was that this was a good thing for Blue Cross to be providing, both because it helped its members. It could be something that they could argue was a differentiator to them. And we actually had just started, when I left, we had started to look at whether we were able to show any increase in days at work for members and their families, because one of the suppositions we had was that by providing better and more supportive care to people who are really sick, we would both potentially get them back to work, which was obviously a big thing, but also we could reduce the stress on family members who might have had increased absenteeism from work. And by doing this, we could allow them to be back at work. And then that goes back again to that earlier comment that I made that said, the person who's buying the insurance company is probably an employer. So if it's an employer that's buying the insurance company, they're going to care whether the people that they're employing are at work. And so if there's a way for you to build something like that in, that can be a really powerful tool to go to an insurance company and say, look, you can talk to your businesses. And when you offer this services, people who need these services are going to have, they're going to be more present at work. And that may be a good or bad thing, but that is something that's going to resonate. And then we also ultimately looked at what we call the PMPM reduction, which is the per member per month total cost of care. And what we did and we're able to show is that people ultimately that were involved in the program had a lower overall cost of care, even though their behavioral health cost of care went up. So they were spending more on the behavioral health side, but at the end of the day, it's all one big pot, and we were able to show that the ultimate medical cost came down. And so in this way, we were able to sort of create a larger picture of sort of what the outcomes were of our program and do it in a way that resonated with the insurance company. So before I open it up to questions, which I'm really looking forward to, and hopefully we'll have a lively discussion, I just wanted to sort of close the loop on that question I had posed earlier, which is why do insurance companies pay for health insurance? And I'm just skimming back through all of these, the answers, and they all answered the way I would have answered, which is that it's done because they want the members of the insurance company to be healthier. I found out that that's wrong. actually. The reason insurance companies pay for health insurance is because they want people who care about being healthy to buy their health insurance. So this is really more of a marketing tool. And the reason for that is because the amount of time it would take someone to get healthier by going to the gym, the chances of that person still being a member of the particular insurance company is very slim. But if you're an an employer who really cares about physical fitness and health, if you're an individual who's buying on an exchange and you really care about your physical fitness, then the fact that you have a gym membership potentially is a differentiator in deciding who you're going to purchase your insurance from. So it's really more of a marketing tool than it is an actual health improvement tool. But I think that gets at sort of the difference. I had always assumed it was exactly what many of you assumed in your answers but after talking to some insurance executives, I was, that's what they told me. And so I think it just sort of illuminates sort of the difference of the way people look at these challenges. But I think it also reinforces that in order for us to be effective in communicating with the people who are ultimately going to be paying, we really need to be put ourselves in their shoes, because ultimately, if we're going to sell this, we got to sell it to them as the payer. So thank you very much. I really appreciate this. Hopefully this was an interesting conversation, and I'm going to open it up for questions. Michelle, are you going to help me walk through those if there are any?
Yes, please. Actually, Ian, can you move the slide one more? Because there's going to be instructions again for folks. One more after that.
That's all I got, I think. Oh, maybe not.
No? Yeah. So I want to encourage folks to turn on their microphones. You can also type in some questions into the chat. I may also have Ian turn off his screen sharing so we can see each other for a little bit as well. We'll bring that back. Ian, just to start things off, I'm just really sobered by that revelation about the insurance companies and the marketing of who they want to be their customers. And this sort of sinking feeling I got in my stomach in realizing that I can't imagine there's an insurance company out there that wants to market to their community that we pay for coordinated specialty care for people with psychotic disorders and those at risk. And anyway, I don't know if other people felt that way too, but I would really love folks to jump in with questions.
Yeah, can I just make one quick comment about that? So I think hopefully it's not too sobering, because I think what understanding what an insurance company is looking for can be super helpful. I think, this is why all of this needs to be a balance, right? If this was just the free market and we were just pitching to insurance companies, then yes, this would be a huge problem. But I think this is why you also have government policy that does things like parity and that kind of stuff. So I think it's all about a balance. And I think the one other thing I will say is that my experience with Blue Cross and Blue Shield led me to believe that there are a lot of good insurance. When we worked with them, they were proactively looking to address this. So I think it's definitely possible. I think but it does create a challenge for us in terms of, obviously what we're talking about are high cost, high needs individuals that, from a strict risk perspective, these places wouldn't necessarily wouldn't choose, but also recognizing that they're going to have them anyway. And so they should figure that out at some point.
For sure. Susan Asrin, it's a pleasure to see you on this call. And I see you may be preparing with a question. So I'd love to hear from you.
Yes. Thank you for being so attentive to realizing that I want to jump in. Thank you, Ian. That was a fantastic presentation. Thank you, Michelle, and your team for putting this together. So I was just thinking about, this, focus on demonstrating to the insurers that whatever treatment we're talking about that we want to be covered by the insurance company, that it can, save money. And I just wonder about, are we trying to make our case on the wrong terms here? Because that clearly is not going to be the case for for some of our mental health treatments. They're not designed to save money, and they many won't. And there doesn't seem to be necessarily an analogous imperative for other health conditions like cancer. You have to demonstrate that, but by providing this cancer treatment, we're going to save the insurer money, because I'm thinking probably it'd be less expensive if the person died prematurely for the insurance company. I just wonder, I'm sure this is not anything new, but I'm wondering how you think about this, where you can't necessarily demonstrate cost savings to the insurer because it doesn't save money.
So a couple of thoughts. First of all, I hope that I didn't make the point that the only thing, I think that's part of the conversation. It shouldn't be the only part of the conversation, because I 100% agree with you that we are providing healthcare, and we have to continue to make that case to insurance companies that this is healthcare. And just like I think you appropriately raised, no one says, why are we paying for this particular cancer treatment? It's going to cost us a lot of money. People just pay for the cancer treatment. And I think part of the evolution of the field, and as we continue to push with insurance companies, we have to continue to make it very clear that this is a medical condition that has cost, and that people have a responsibility to fund and pay for, because it's the right thing to do for care. So I hopefully what I was not trying to say was that that's not important, or that that's not something that we should continue to push. I think while there are while we certainly shouldn't only focus on care, on the cost of care, I do think some of the interventions we're all talking about will save costs based on sort of based on the other, potentially other cost profiles. So for example, if we have, one of the things we found when I did Health Path, it wasn't that we were saving costs if you took the client that we had and compared them to someone who didn't have a significant mental illness. We were still way more expensive than that. But when you took the client we were serving, and you looked at their 1 year to the next year costs, our costs were so much lower the next year, or over a couple of years they were lower. And so that, but I think the key is to be talking about this on a number of different scales. We can't just say this is a clinical outcome. We have to be able to say this is a clinical outcome. This is a this is a fiscal outcome, because it's a good use of your investment. And we also need to think about things like the NCQA standards that I talked about earlier, which are, that's something they're going to be pushed on. So if your program might increase cost, but it also is able to ensure that people who go to the emergency room get a follow-up, I can't remember if it's 3 or 7 days that they're supposed to get it, but regardless, within that time frame, the insurance company, that's a huge benefit for the insurance company, because typically that's a population that probably doesn't hit that measure. So I think it's about trying to understand sort of in whole all of the different measures. But I couldn't agree with you more that at the end of the day, this is medical care, and they should be paying for it. Having said that, we have to make sure we can at least get in the door, and so we have to be able to think about the larger how is the most effective way to get in the door and to get these things paid for, and so that we can continue to grow them and get them to more people.
So could I ask, do you think it's a concern that, that an insurance company maybe wouldn't want to have excellent benefits for people with serious mental illness, early psychosis, if the other insurance didn't, because this is a high cost group? So I know there's a term for this, and I know you know it. They don't want to attract people.
Sure. I think it is, and I think it's why we need policies around sort of parity and all that kind of stuff. That if you don't do that, then you do run that risk. That was one of the real driving forces behind sort of this concept of that when the Obama administration pushed forward the health exchanges, right? This idea that everyone had insurance, right? Because if you can really cherry pick and say, well, I'm only going to take the healthy people, then from a business model perspective, that makes a ton of sense. from a what you're there to provide perspective, it really doesn't. And so I think you've got to balance those two things. And I think absolutely we run the risk of, I've gotten the most attention from insurance companies around when I've gone forward and pitched them on different prospects, really has historically the way in the door is to talk about cost savings. It is a double-edged sword. It gets you in the door. It's true in many ways, because I think we can manage these people much better than if they're not managed by us. And so I think there's opportunities there, but I could not agree with you more that we shouldn't, hopefully we get to a point in the not too distant future where that's not as necessary, that people are really understanding better sort of how important providing this kind of care is, just from a social justice and good care perspective. This is a disease like any other disease, and people deserve treatment for the diseases they get. But we have to live in the world we live in, unfortunately.
Right. But do you think it's feasible to just focus on like one insurer at a time? Like, would one be willing to offer these what might be seen like enhanced benefits for a high cost population versus just attacking a large approach?
Yeah, I think it can be challenging, because obviously you got to get in the door. Yes, I think some are, because I think the ones that are smart recognize that they have people with this condition already. Just very quickly, I remember an early on conversation with Blue Cross of Rhode Island, who was a real partner in this. And we were sitting not with the behavioral health folks, but some of the higher up people at Blue Cross, who were sort of in management. And we were talking with them, and then another medical provider who did mostly commercial business, didn't do a lot of Medicaid business. And they were saying, well, we don't have members in our population that fit this profile. And we said, oh no, you do. Yeah. And so I think they're beginning to understand that they do have these members. And, we're, unfortunately for us, we're probably 20-ish years behind the rest of medicine. I mean, we're catching up. Not because we ourselves are behind, but just because of sort of the understanding, the stigma, et cetera. And so I think, there's a little bit, we still got a ways to go, but I find it much more, them much more open to the conversation, because they see it both as, well, we can't stop these people from coming in. We're going to have them. And so we may as well figure out how to deal with it.
Great. Thank you very much for this discussion. I sort of an interesting parallel process of the Cedar Clinic became a part of the Brookline Center about 2 years ago. And so this kind of conversation that you're having with Ian is one of the things that's been very refreshing and helpful to me, is that we lived in a fantasy world up until 2 years ago, where we never worried about what was paid for at all when it came to our program for youth at clinical high risk for psychosis. We just did what made sense, and we worried about none of it. And Ian's been really sort of pulling us into the real world in terms of thinking about sustainability and scalability of a program like ours. Like it or not, we need to come in the door with insurance companies speaking their language. Unless we're able to speak their language, we're not going to be able to advocate for our clients to get the services that they need. And so even if, so it's been a really steep learning curve for us as well in coming at this and taking this perspective. So there's a few questions in the chat that I want to highlight. So Dan Shapiro, hi Dan, in our program, he says, in our program, we struggle with building the case for reimbursement of some of our coordinated specialty care components, particularly peer services and supported education and employment. Do you have any suggestions for building the case?
So a couple of thoughts. Some of this has to do with what is an unfortunate reality in our current funding system, where things are often siloed, even though in reality they don't exist in a silo. And so I think it can very well often be a challenge around, especially the employment stuff, where insurance companies will say things like, well, that's not our problem, that is someone else's problem. sort of forgetting the fact that providing access to a good job or getting someone more stable is likely to not only improve their earnings, but also likely to improve their mental health or their functioning or whatever. So I think, you have to be a little creative. We were able to do it through bundled payment, where we were sort of able to bring the whole and have them pay for the whole and then allow us to sort of break out the parts. So that would be my first recommendation, as best you can. And it's not always easy because insurance companies are the master of the widget, right? They really want to know how many widgets you've provided. But if possible, to try to push it more towards an overall, we'll provide X amount of hours of service. We'll provide, the access to all of these things, and doing that in a way that potentially allows for you to sort of figure out what the best way to provide those services are. The other thing that I would say is that it's really important to be able to track both who provides the services and then hopefully to some extent tie that to outcomes. One of the things that we did actually have peers and case managers in the program that I talked about earlier. And one of the things that we were really able to show was that the intervention of those people could be tied to better outcomes. The specific outcome that we were really able to show was much better engagement on the peer side, which doesn't surprise anyone who's who's used peers in any kind of, because they've had lived experience and because they can actually sort of relate to the client or the patient in a way that in a way that that even the most skilled clinicians couldn't, right? Because they've been there. That they were really able to help with engagement, and so we were able to show that an early connection between a peer and the client led to better engagement. And I think that was something that was really important, that we could really show the activity. And the way we were able to do that was to go, we used our electronic health record to really track each individual provider in a way that, and what services they were providing, whether it was face-to-face or telephonic, so that we could tell that story. But it is definitely a challenge because it doesn't fit within the normal, both, what insurance companies normally see as their responsibility, as well as, the sort of the traditional medical model.
Thank you. So we also have a question from Mark Fagan, indicated he had a couple of short questions. Do you want to jump in, Mark? Or if you're not ready to jump in. Oh, sorry.
Can you hear me?
Yes.
Yes.
Hi, guys. I was just saying my daughter must have messed with my camera setting, so I'm not on camera, but I can see some of you, and it's really great to see some familiar faces. So first of all, Ian, thank you for your thoughts and wisdom on this. We, as you may know, in Illinois, we were able to work on 2 bills in the past year for law, one in regards to Medicaid coverage for young adults with early psychosis, and then the more recent one for commercial insurance mandate to cover both coordinated specialty care as well as ACT for young adults. And so one of the questions was really around that support employment and education. And so Daniel asked that one. That was great. The other thing I was curious about is, in terms of Health Path, first of all, were you able to get folks that are not licensed, credentialed under the bundled rate and everything? Because that's one of the things that we see as an issue across the country, is that, clinicians or other disciplines cannot get credentialed by insurance for that reason.
Yeah, so we were able to get around that. My recollection is the way we did it is we billed as a not site, that's not the right word. I'm thinking, but basically we were an entity that was, the billing was under the program. So it was a program billing. And then we had, and we were providing the services underneath that. So we didn't bill for the specific services. We obviously had our clinicians independently, our independently licensed clinicians were registered with Blue Cross, but other services we didn't. We just filled the service. Now we were a little bit of a specialty, we were sort of a pilot that they were working with. So there was a little bit more flexibility in how they were willing to do that. But there's definitely ways that insurance companies can do it. I think there are a couple of general challenges just in general. One is, one of the big things I'm thrilled to, I did not know that Illinois had done that. I'm thrilled to learn that they did in terms of mandating the coverage. I think one of the things we've struggled with a little bit in Massachusetts is, it's one thing to mandate it, but then what I often find is the problem is the states don't follow through and then ask for some level of similarity between the different providers. So what often becomes a problem is, like, for example, we have in-home therapy services that Massachusetts recently mandated be covered by commercial insurance providers. The problem is Massachusetts didn't mandate that the commercial insurance providers require billing in the same way. So we've now have like 20 different ways that we're supposed to, this one wants this modifier and this one wants this modifier and this one wants it billed in 15-minute increments and this one wants it billed in hour increments. And, and as there's, it gets to the point of crazy. So I think one thing to continue to advocate for and continue to push the states who I think are starting to see this as a real, something that they need to do is to really encourage them to also be willing to put their foot on the scale a little bit with the insurance companies to say, look, it's great that you're offering it and paying for it, but, paying for it in the same way as everyone else might be a reasonable thing to ask.
Yeah, that makes sense. Yeah. And I mean, for us in Illinois, part of the additional challenge on top of some of the things you talked about and incentives for the commercial insurers is also the movement that young adults make, right? So a lot of them might be on their parents' insurance and then move on to their own or move on to Medicaid. So that adds an extra layer there. And that's part of why we went the legislative route. One of the things I think to your point that was interesting and that somebody asked about different insurance companies, one of the things that we did and that we're continuing to do is work with the Department of Insurance in Illinois, and they are sort of working on getting the collective views of all the insurance companies in the area. So that's one approach that we've taken that seemed to work a little bit better.
Thank you very much, all of you. I'm realizing we're just about out of time. Ian, if you'd be willing to share your screen again, I just want to alert people to the next discussion that's coming up in June as well. And I see that there are way more questions than can possibly fit into this hour. So hopefully, if it's okay with folks, to be in contact, Ian, if it's okay with you for folks to be in contact with you or to direct questions to me, I can also work on trying to get those questions answered as well. So Ian, can you go to the next slide, please? Thanks. So our next discussion is going to be on June 10th at 2 o'clock, and we are excited to be welcoming Drs. Bao and Dixon to talk about a payment tool that they've developed for being able to calculate and use in negotiations with payors, insurance companies, around trying to figure out what the bundled rate should be, depending on where the clinic is located, the intensity of services, and so forth. So that should be a really interesting discussion in June as well. So just again, want to say a huge thank you to Ian Lang for joining us today, and for everybody that's participated and spent their Wednesday afternoon with us, everyone that's doing work in this area to make these kinds of services more accessible to our patients. I really just am so impressed by the work that folks are talking about in the different discussions, and every piece that is done in Maine or in Chicago or in other places makes a huge difference in being able to lead the way for the other states and other programs to be able to make their programs and their work more accessible. So thank you again to everybody.
Thank you.
So